Welcome to Embedded Conversations. I'm Scott McKenzie. I work with NHS leaders, commissioners, and life science organisations to help them navigate changes to patient pathways, changes that actually stick. Not just pitches, presentations, or good intentions that fizzle out after 6 months. I'm also the author of Embedded, a book about what it really takes to land ideas, innovations, and partnerships inside complex systems like the NHS and keep them there. My podcast, Embedded Conversations, brings those ideas to life. In each episode, I sit down with the people who've either been in the system or are currently working in the system. Real NHS leaders, commercial innovators, and cultural voices who talk honestly about what works, what doesn't, and what it takes to embed change in the real world. You can expect practical conversations about power, trust, commissioning, culture, and delivery, and how all of those things collide when you're trying to land a new project to improve patient outcomes. If you're working in, around, or with the NHS and you want to understand how change really happens, you're in the right place. Hi everyone, and welcome to the latest Embedded podcast. I'm absolutely delighted to have one of my longest standing customers, Dr. Paul Netz. Paul is a GP based in Newcastle upon Tyne, and as I say, very long standing colleague and customer, really since the very early days of the consultancy, way back in 2006-07. And over many years, Paul's consistently been at the forefront of rethinking how care can be delivered differently, not in theory, but absolutely in practice. And that's really what we're going to get Paul to hopefully open up and talk to us about today, because Paul genuinely pushed the boundaries of what primary care can do through his leadership. He previously held a hospital subcontract that enabled him and the wider team to deliver services that would traditionally have been provided in secondary care, much closer to patients out in the community. And that was long before it became national policy. Paul was already demonstrating what we would now call left shift from hospital to community, and it was absolutely there working on the ground. So his work represents a real world model of integrated care in action, where general practice, community services, hospital care, all aligned around patient need, really improved outcomes and system efficiency. Now, at the time when the 10-year plan and Lord Darcy's vision are calling for exactly this kind of transformation, Paul's experience offers us a real practical insight into what's possible, what's hard, and what genuinely works. So, Paul, it's an absolute pleasure to get you on the podcast today, mate.
Thank you very much, Scott. That's very kind of you.
Not at all. It's just how it is. That's the reality.
Well, thanks to you as well.
Well, yeah, I played a part in it, but in fact, let's start there. Can you kind of talk to me a little bit, and mostly for the listeners, explain what it means for a GP to hold a hospital subcontract and how that's different from the kind of more traditional models of care that we have in the NHS? It's a good place to start, actually.
Yeah, well, I mean, I think your listeners, I'm sure, will be familiar with the normal contracts that primary care has with primary care agencies, but to get one from secondary care, or certainly in our case happened to be tertiary care, was valuable, because I think that the hospital were very open to it, because I think they felt that they had a lot more control over what was going on. Having said that, there were negotiations to be made, and it has to work for everybody, clearly, else there's no point in carrying on. However, they were very amenable to it. In fact, more amenable to it than I thought they would be. But they weren't greedy, I don't think, with what they wanted.
Nope.
And I think that was a sign of how keen they were to do it.
I can remember it way back when it first happened. The GP Federation, as it was in those days, was very early in its formation. In fact, you were one of the GPs that helped me pull the federation together. And then the very first thing we got was a subcontract for ambulatory blood pressure monitoring.
Yeah.
And as I remember, it was Jane, who was the cardiologist, and Louise, who was the paediatric consultant, had lunch with each other as a start to the conversation. That
Yeah.
Jane mentioned to Louise, "Oh, we've got a subcontract," and that sparked interest. And then all of a sudden, you knocked on my door and said, "Scott, the hospital are kind of amenable and interested in subcontracting non-mediated IgE pediatric allergy." And I remember saying to you, "Right, Paul, you need to explain to me what that is."
Well, and yes, I mean, obviously the hospital they can't contract at that level with individual practices,
No,
but so it had to go through the federation,
yeah,
which was fine.
yeah,
Um, and what one of the advantages I think from everybody's point of view was the speed with which it was done. It was done pretty quickly.
yes,
And when there's a will on both sides, you would hope that things
yeah, it
would
really
move
moved.
quickly.
Yeah,
Honestly, obviously with NHS, things often move at a glacial pace, but this was definitely a refreshing exception that proved the rule.
it really was. Just to, again, for the benefit of the listeners, what kind of services were you providing under the hospital subcontract? And go a little bit further and just explain how that arrangement really benefited the patients compared to being managed solely in a secondary care environment.
Well, we excuse me, we got the subcontract to provide pediatric allergy outpatient services
Yeah,
for the hospital. So we being the federation.
yeah,
Um, and myself and one of my other GP colleagues wanted to move this forward. So in order to do that, we sort of drew up a to-do list, things we needed to
yeah,
get this done, which included going back to the hospital and asking to employ their staff.
yeah,
So it was a sort of, which was a very difficult concept for a lot of people, including especially the consultants, to work out. So we employed one of the consultants to teach and supervise us. We employed one of the allergy specialist nurse to help
yeah,
us run the clinic, and essentially that was it. But we required training, which they
yes,
provided. We required, as I say, nurse help, and initially we had a dietitian as well.
yeah,
Although, due to problems with the dietetic service, they weren't able to carry on with that. But that wasn't as big a blow as we thought.
yeah.
So we could do it very quickly with relatively few people. We needed rooms, but we
You had the
were
space.
able to do that in the
Yeah,
surgery, so that wasn't an issue. And so we were contracted to supply the services, but we went back to the trust to get the staff to help us to do that.
and-
So, uh, um, and it meant that the hospital were happy because they knew the people
yes,
that we were employing. They trusted them.
yeah,
They jumped through all their hoops. Um, and also it got us a connection with secondary care that was close and workable, and
yeah,
also a two-way thing as well. Whilst we learned a lot more from them, there was a lot that we could tell them about primary care
yeah,
and that sort of thing. So it's been everything that I hoped it would be. I've got to say, feel
yeah.
extremely lucky.
I remember the very early days because I remember when we, as you say, but there was quite a bit of negotiation around the business case to sort it out and what the contract was going to look like and all of that, the kind of the technical bits that went on in the background. But I also remember the kind of the joy of the very early patient feedback about the fact that they liked the fact it was in general practice. There
Yeah,
was a tram stop. There was a great big free car park, and I didn't have to turn up 2 hours early to try and get a parking
yeah,
space like I did at the hospital. Oh,
yeah,
and if that didn't work, there was a bus stop literally right outside the practice.
yeah.
So the patients engaged really quickly with the service. We didn't have any lumps and bumps with that. There was no real objection to moving it from in hospital into local general practice in the east of the city. It worked really well.
No, we did. I mean, and we did the appropriate
Yeah,
feedback forms, which have persistently said all those things. free car parking
Yeah,
seems to be a huge thing,
huge
doesn't
one.
it? But just access in general. But people travel from throughout the region. We've got people traveling from the west coast to the east coast to
Yes,
come and see
yeah.
us, and they still don't seem to mind. So it has been a success from that point of view. There's no two ways about it.
What are the beyond that kind of the day-to-day delivery? What do you see as the operational and the financial benefits of the model for the practice, the trust, and potentially the wider system?
I think that, excuse me, financially, uh, everybody won, really, I think.
Yeah, true.
Certainly, the Federation won. Having moved to block contracts was a bit of a kick in the teeth, actually.
Yeah, it was a bit.
But initially, we were paid case by case. So
Yeah,
that worked very well because we negotiated a price for our
yeah,
services from that from that money. We were only seeing follow-up patients.
yeah.
For clinical governance reasons, they felt that it'd be best if they'd already been seen by a consultant, which is fair enough.
That was absolutely
But
fine.
it
I remember that. Yeah,
also, because we were doing a lot of the follow-ups, it freed up the consultants to see more new patients, and therefore the tariff was £100 higher for a new patient than it was
yep,
for a follow-up. So they're happy from that point of view. They were also happy because they took there was a tariff for the skin prick testing, which was done
yes,
in two-thirds to three-quarters of our appointments. So they took that. And also we bought their nurse time for our clinic, but the consultant who was running a parallel clinic,
yeah,
they used that time, so they got a free nurse out of it.
yeah.
Um, I think politically it suited them
It
well.
did.
I think to be seen to be supporting this, I think
Yeah.
was something that they were pleased about, and they could sort of shout out to primary care, and we are engaging with you better together
Was the word? Yeah,
was the
that was
name
it.
of the sort of movement or policy at the time. So that it was a concrete example for that. It helped them because they had a big waiting list, and we reduced that.
Well, I was having
Um,
a look at the papers because I knew when I was coming to talk to you, so I went back to that original business case. And actually, it's eye-popping when you look at the volume that adding you and the other GP. I'm not going to name them because it's not important to the
yeah,
listener. But adding the two of you to that literally quadrupled the volume that the hospital could manage. And it meant, as you say, that we freed the hospital team to be able to do the first outpatient appointment when they were still trying to work out mediated, non-mediated, who is it safe to transfer to the GPs. But the other thing that I loved about your approach was because you based the consultant out beside you, it meant that you never needed to call a patient back or send them on. You literally had the consultant working alongside. It worked so well as a concept.
yes, it did. And the other thing that we found out is that we, as GPs, are better at discharging people than the hospital people are, because we know what our colleagues can deal with.
Yes,
And
totally.
the consultants, in my experience, underestimate what GPs can do. And so we're discharging people, and they're saying to us, "Oh, should you be doing that? What about?" And said let's meet and drink. This
Yes.
is not a problem.
Yeah. Yeah.
And if there's ever anything around, if there's a ear, nose, and throat problem, or there's an asthma problem, or whatever that might need
Yeah.
something, the consultants always think to refer to their colleagues, when in
Yeah.
fact, 9 times out of 10, the GP can deal with that. So
Mhm.
it's been interesting from that point of view.
I mean, that leads in really neatly to you've kind of opened another little area that I want to look at with you, which is when you worked alongside the hospital consultants as part of really a multidisciplinary team, was it a case of greater collaboration or did it create friction? Was there any lessons that people need to be aware of? Was there any friction or was it pretty straightforward?
Well, I think that's down to personalities, really.
Okay,
There's been absolutely no friction at all.
that's what
It's
yeah,
been a pleasure. As I say, I feel very, very lucky. I think we have hit lucky to a degree, but then I think that consultants select themselves. I don't think anybody
Yeah.
who consultants who are willing to engage with this sort of work want to listen to what you have to say.
And I'm
And
absolutely
it's
certain if I had Louise here, she'd say exactly the same back to you. Oh,
yeah.
I landed really lucky.
Well, it's worked out very nicely. And I
Yeah.
think, as I said to you before, I think, we've learned an awful lot more from them than they have from us. However, there's definitely been a two-way flow. We even did a video consultation about how to consulting technique, skills, and that sort of thing, which went down phenomenally well with the
Ah,
team. So they
brilliant.
are keen to know what's going on. And it amazes me how little they do know about primary care. I
Mm.
mean, it is staggering. I mean, even the ones that are primary care friendly,
Mm.
which are the majority, but they what they don't know is eye-opening.
I get it in my work all the time. The complete misunderstandings over how you're contracted, how you're funded, the volume of work that you manage. There's really no concept of what goes on in primary care
Oh,
until
absolutely.
they come and actually work alongside you.
Yeah.
Um, do you think there's opportunities in here for the pharma, medtech, and device companies to support and really enhance the kind of the care through a subcontract? Is that an opportunity?
I think without doubt it's an opportunity. I think that yes, it's a way, and I think the hospitals do value it as a model.
Yeah.
I think that pharma could definitely support projects
Mm.
in various ways, as long as the conversations initially setting it up
It's pathway. It's got to
were
be
clear and
pathway.
transparent.
Yeah.
Yeah, and I think that have to be very clear at the outset. But as long as it was set up and the contract was watertight to start with, I think it would work extremely well.
Yeah, I agree. I mean, I agree with that entirely. I think this is where you really want a pathway over a product approach. You want to talk to them about an end-to-end pathway,
Yeah,
what we're trying to do and achieve, right patient, right place, right time, right healthcare professional, and exactly what we did with your subcontract. The resources were put in place to enable you to deliver the contract. And I think if you do that and do it well, industry's absolutely got a role to play in being part of
yeah.
that pathway. If we've got people listening in today, and I'm sure we will have, either GPs or federations or primary care networks or even neighbourhood teams who might be considering a subcontracting model, what's the one bit of advice you would give them? What would you say to anybody thinking that might be the way to go?
Ring you, Scott.
It's very kind of you, but there must be more to it than
No,
that.
but I mean, no. Joking aside, I mean, I do think somebody with management experience, and knows the both sides of not both sides, but knows the whole picture very well. Your help was invaluable, and we definitely could not have done it without you. I think that you've got to be clear about what you want to do.
Yes.
And I think that as long as it's very clear about what you want to do, what the benefits are for the patients, what the benefits are for everybody, and there are lots of things that can be done. I know that one of the hematologists recently approached us because they're doing something for sickle cell with
Right.
GPs. And so there are things that are appearing all the time, and I think it's
Yeah.
just about having conversations with consultants because there are lots of that they don't think about these sorts of things. So I think that there are very clear problems that could be resolved, dealt with primary care, but just have a very clear vision of what you want to do
Yeah.
and get help from people that make sure that you don't miss anything out and that to help you with contracts, help you negotiating if you haven't got that sort of experience. I think you've got to be honest about what your skills are.
Yeah.
And you know, lots of GPs are not business people because that's why we're GPs. So I think that to have business expertise is really important because what happens at the very beginning defines everything else.
You know what? I couldn't agree more with what you've just said there. And actually, what that set me thinking about was the other contracts that then came off the back of the work that you did. because
Yeah.
we then ended up with Diana Mansour in community services,
Yeah.
community gynae contract, 5 bits of work on subcontract. I then used the model. I connected Newcastle hospitals to the George Eliot Hospital in Nuneaton and the GP Federation there, Primary Care Warwickshire, and they ended up with hospital subcontracts that kind of matched and mapped against the model that you first established in Newcastle. So we didn't kind of do it and then go, right, we've done that in Newcastle, let's go and start all over again with a blank sheet of paper. We took the learning into other areas, and I've had so many different hospital subcontracts now, things like, well, the gynae, the cardiology diagnostics, insulin initiation and titration, GLP-1 initiation. There's a whole plethora of different things that came out of that model.
I think a direct approach to a consultant, say, look, what can we help you with?
Yeah,
I mean, even as simple as something as simple as that might bear fruit, because they'll
yeah,
have an idea of what they would want help with, but they're just probably too busy, or they've got a million and one other
totally.
things where they actually haven't thought about it,
Yeah,
or had time to make it happen.
yeah.
So a direct approach saying, look, I'm interested in respiratory, I'm
Yes.
interested in whatever, how, what can I do? And I think people would be
I think it
surprised.
is as simple as that, because if I go to, I can think of consultants today that I could pick up the phone and speak to. And if I was to say to them, where are your bottlenecks, your backlogs,
Yeah.
where are you handing off patients because you haven't got the capacity, they'll have a list of things. And it's then the point that you've just made. Can you see a way that you could actually support and deliver and work alongside them and actually smooth out the pathway? That's where the subcontract
My,
is ideal.
And I think that consultants want GPs working in their clinic. One of my appraiser was an adult rheumatology specialist, and she said, if I've got a GP working in my clinic, I don't have to worry about them because of their breadth of knowledge.
Yeah,
That's what she said to me. So we're a valuable resource, not just in primary care, but
super.
with secondary, tertiary care as well. So I think there are definite opportunities there, no question.
Oh, thank you, Paul. What an absolute pleasure. I can't thank you enough for coming on. This is exactly what I was hoping we'd be able to share as a
No,
bit
it's
of an
my
insight.
pleasure's all mine, Scott. Pleasure's all mine.
Thank you, mate. Nice to see you. Thanks again.
And you.
Bye now.
Bye-bye.
Bye bye. If today's conversation has struck a chord, it's probably because you're dealing with similar challenges, trying to move something forward in a system that doesn't change easily. That's exactly why I've created the Embedded Edge. It's a community for people who don't just want insight, but want a competitive advantage, clearer thinking, better positioning, and a much deeper understanding of how decisions are made inside the NHS. Inside the Embedded Edge community, I share practical frameworks, real world analysis, and behind the scenes thinking drawn from live NHS work alongside others who are grappling with the same questions you are. If you want to start sharpening how to show up, how to engage, and how you embed what you're trying to do, you'll find much more at www.scottmckenzieconsultancy.com. Thank you for listening to Embedded Conversations. And if this episode got you thinking, make sure you're subscribed, as there's plenty more to come.